Thank you for joining our Debbie Stream Foundation webinar series. Today's webinar is featuring Dr. Brian Badgwell, who will give us a presentation on Is Curing Stage 4 Gastric Cancer Possible? I'm Brittany Starks, Communications Director for Debbie Stream Foundation, and I will be moderating today's webinar. Next slide, please. We would like to thank our webinar sponsors, Platinum sponsor Amgen, Daiichi Sankyo, and Merck, Silver sponsor Bristol Myers Squibb, and Bronze sponsor Seagen. Next slide, please. First, I will share information about stomach cancer and Debbie Stream Foundation. Then we will hear a presentation on Is Curing Stage 4 Gastric Cancer Possible with Dr. Brian Badgwell. The presentation will be followed by a Q&A session. Next slide, please. You can type your questions throughout the presentation into the chat section that appears in the webinar menu. We will address questions at the conclusion of the presentation as time allows. Next slide, please. This year, nearly 30,000 Americans will be diagnosed with stomach cancer. Stomach cancer is the second leading cause of cancer deaths worldwide after lung cancer, with a dismal 5-year survival rate between 20% and 30%, depending on the country. Many patients are asymptomatic during the early stages of stomach cancer, leading to late diagnosis. Next slide, please. Debbie Stream Foundation is dedicated to raising awareness, advancing funding for stomach cancer research, and providing education and support internationally to patients, families, and caregivers. Our ultimate goal is to make the cure for stomach cancer a reality. You can learn more by visiting our website at www.debbiestream.org. Next slide, please. Pictured here is Debbie Zellman, the founder of Debbie Stream Foundation. Debbie was diagnosed with stage 4 stomach cancer in April 2008. She had no risk factors and only vague symptoms. At the time, she was told that her chances of being alive in 5 years was only 4%. Debbie founded DDF in April of 2009 and dedicated herself to helping others with stomach cancer by raising awareness and providing resources and education. Simultaneously, she endured harsh chemo regimens and targeted treatments and experienced many reoccurrences. Unfortunately, Debbie passed away on December 29, 2017, at the age of 50 after a 9.5-year battle with cancer. As an organization, DDF continues her important work and legacy. Next slide, please. In a few short years, DDF has achieved many great milestones. We have 32 chapters across the US, including Canada and Germany. Our PrEP program helps patients, their families, and caregivers match with survivors and caregiver mentors using disease-specific criteria, including stage, biomarker, and location. We host educational webinars and symposia year-round, and our website contains in-depth information about stomach cancer. We also have provided $1 million in research grants to date. Next slide, please. Each year, patient advocates come together at our annual Debbie Stream Advocacy Day with the ultimate goal of securing funding from the Department of Defense's peer-reviewed cancer research program. This program allocates funds for stomach cancer research. This year, we hosted our second virtual advocacy day with more than 130 registrants. Join us next February for our 11th annual advocacy day. Next slide, please. Here you can see some of our upcoming events. Next week, we have our monthly stomach cancer support groups on March 3rd. On March 18th, we have a webinar on immunotherapy and targeted therapies for gastric cancer patients. March 23rd, we have our Mind, Body, Spirit series on Facebook Live, episode 2, all about acupuncture. May 20th, we have episode 3, all about meditation. And June 18th, we have our International Gastric Cancer Educational Symposium. And in August, we have our Miami Cancer Institute and DDF Symposium. To learn more, visit our website at debbiestream.org. Next slide, please. DDF is headquartered in Plantation, Florida. Our office hours are Monday through Friday, 8:30 a.m. 8:30 a.m. to 5 p.m. Eastern Time. Also on this slide are important phone numbers and email addresses that you can use to contact our office and staff. Next slide, please. We will now begin the presentation on Is Curing Stage 4 Gastric Cancer Possible with Dr. Brian Badgwell. Dr. Badgwell has a cancer-directed practice in gastric and gastroesophageal cancer at MD Anderson that incorporates recent progress in advanced laparoscopic surgery and intraperitoneal chemotherapy in the treatment of patients with gastric cancer. He has worked tirelessly to improve outcomes for the most common site of metastatic disease and site of recurrence in gastric cancer through clinical trials of HIPEC. Dr. Badgwell performed the first laparoscopic HIPEC at MD Anderson and now serves as a national and international referral source for the surgical treatment of gastric cancer metastatic to the peritoneum. Dr. Badgwell has performed over 100 HIPEC procedures for gastric cancer, which is the largest single surgeon experience for this disease in the United States. We would like to thank Dr. Badgwell for taking time out of his schedule today. And now, Dr. Badgwell, I will turn the presentation over to you.
Okay, well, it's a high honor to be here today with you and talk about really just a tough question. This is a tough question to answer. Can stage 4 gastric cancer be cured? But it's my life goal to do that. I think we've made some headway, and at the end we get to decide how I've answered this question. So I think it's going to be a lot of fun. All right, now I have no disclosures. I've never received any pharmaceutical money or grants or consulting fees or really anything. All the research I'm going to talk about in the drugs are really standard of care for the treatment of gastric cancer and just used in a different way. You know, I did just want to mention one thing before I got started, that you know, it's a real pleasure being here with Debbie's Dream Foundation. It was the first advocacy and patient education group that I met in my career when I came to MD Anderson. And so here's a picture of me back in 2015 at one of their stomach cancer educational symposiums. It's like a Geico commercial. It looks at how life comes at you fast. I've aged quite a bit in those few years, but it's just a great organization. So again, it's just a pleasure to be here. And I had the chance to meet Debbie during that time, and I'm glad I got to do that. It's just very inspiring to be a part of that and to get to be a part of some of the patient panels and just interact directly with patients and help educate. And so anyway, I've tried to stay as engaged as I can over the years. So okay, so where the outline is first I'm going to talk about, you know, where does gastric cancer spread? You know, what does stage 4 gastric cancer mean? I know a lot of people that are watching this know what it means, but I think you know, we can talk about how that influences treatment, and particularly when we start to talk about more aggressive treatments, and that includes surgery. I think it's important to discuss if there are different types of stage 4, because really, you know, stage 4 isn't one type of cancer. It's many different types, and it's treated different ways with different options. And so I wanted to talk about that a little bit. I think it's also very important to talk about whether cancer is different between Asia, which I'll refer to as the East, and the West, which, you know, we're talking about Europe and North America. And I think the short answer there is that it is different. So you have to be careful interpreting data, and it can get very confusing, especially recently as we've seen some of the data from the East make its way into the American Joint Commission on Cancer staging and some other treatment guidelines. So we'll talk about that. I'm going to talk about what HIPEC is. I do not like to use abbreviations when I talk to patients and caregivers, but this one gets used a lot, so we're going to have to define it. It's heated chemotherapy within the abdomen. I'll talk about it more. I did want to talk quite a bit about how HIPEC has been used for gastric cancer. And I'll take a step back and talk about whether chemotherapy should go via the vein or into the abdomen, and if it goes into the abdomen, how should we do that? I think a big question is, should the stomach be removed in situations of stage 4 gastric cancer? It's a tough decision. I have this discussion a lot, several times per week. This is all I do is treat gastric cancer. And so this is a very common question that we answer. And so I hope the talk today is helpful in that. And then really, how should surgery be integrated into standard chemotherapy? You know, systemic chemotherapy is the standard of care for metastatic gastric cancer, plus or minus immunotherapy. That's the new kid on the block that's being used. And then at the end, I'm going to tackle the toughest question. So, can it be cured? You know, it's been a passion of mine to try and do that. So let's see how we do that. All right. So first of all, where does gastric cancer spread? Well, you know, the liver and the peritoneum are often competing to be the first site of metastatic spread. If we're talking about gastric adenocarcinoma, which is the most common, kind of the garden variety, what we really think of when we think of gastric cancer, it's the peritoneum. But the liver's up there too. It also goes to the lung quite frequently, distant lymph nodes, rarely the bone, very rarely brain. That tends to be more proximal tumors that involve the top part of the stomach. And I just wanted to show a picture here of the stomach. So here's the esophagus that comes down into the stomach. And these are lymph nodes around it, draining regional lymph nodes. And so when I say distant lymph nodes, I'm not talking about these lymph nodes. These lymph nodes are easy to remove and part of standard surgery for gastric cancer. I'm really talking about lymph nodes that are farther away. So, you know, the lymph nodes that are around the aorta, one of the big blood vessels in the body, or the kidneys and the veins. Sometimes even farther away, like in the neck or above the clavicles, places like that. So that's what I mean when I say distant lymph nodes. And then don't worry, I'll define what the peritoneum is as well. I know that's a doctor term we throw around quite a bit, but I want to really talk about that. So what is the peritoneum? Well, the best way I found to describe this comes from a patient, and I've borrowed it extensively, and I use it several times per week. But I think to define the peritoneum, it's best to think of the stomach as being a pillow that's within the pillowcase. You can get in between the pillow and the pillowcase, which is what we're seeing here, and the pillowcase is the peritoneum, and you can look around. And that's what we're doing here. We're using laparoscopy, where we use air, or in this case CO2, to distend the abdominal cavity between the pillow and the pillowcase, and we can look around. And so this is the stomach here. Here's the top part of the stomach, and food comes in here and moves down that way towards the end where it starts to turn white. That's what the tumor is. It's white. This is normal stomach. I'm going to try and use one of my highlighters here. So this is normal stomach down there, and this is the tumor around here. And you can see it jumps off here, and this is where the white dots go to the lining of the abdomen. And you can only pick that up sometimes with laparoscopy. This is normal liver here. So that's the peritoneum. All right, now, so what does stage 4 mean? Well, I think that's best defined by going to the American Joint Commission on Cancer Staging Manual, and it defines 5-year survival as being 5% in stage 4 disease. And it's basically classified in the the NCCN, the National Comprehensive Cancer Network guidelines, as being not curable, meaning we can treat, we have a lot of treatment options, but we can never get rid of it. Now, if you look at median survival rate, so it's interesting to talk about what a 5-year survival rate and a median survival rate is. So 5-year survival, the reason we use that 5-year number is that if we can get to 5 years after surgery, for instance, and the cancer hasn't come back, that's basically what we consider a cure. The vast majority of cancers, if they come back, will do so within 5 years. We have a few cases of heartbreaking recurrences after that, but that's really rare. So similarly with stage 4 disease, if you can get to that 5-year point, but I'm not sure we can consider that a cure in stage 4 disease. Now, the other way to look at that is median survival. And so that's a middle survival. Now, you always see in the movies where a doctor will tell a patient, you have this amount of time. It doesn't work that way. We don't know that, and we're notoriously bad at trying to predict that. But what a median survival rate is that middle survival rate. So if I had 100 patients, that middle, patient can be at 6 months, a year, depending on the site. But it's a whole spectrum. So there are some patients that just live, unfortunately, a few weeks, but some patients that live many years. And so, but I think, I try not to discuss numbers or give numbers, but I think sometimes, it's helpful to talk about ballpark figures, and even though we don't know an individual patient's length of life, we can give numbers that can kind of help provide some context. So I hope that's helpful to think of it in that terms. What else does stage 4 mean? Well, as I mentioned, if you go to the National Comprehensive Cancer Network, it'll provide guidelines for physicians and also guidelines for patients. And it really lists things as palliative management only, meaning systemic chemotherapy or best supportive care. And if you go look at systemic therapy, it says do the first-line chemotherapy. That's the best chemotherapy we have. And you do that until there's some toxicity. Most often it comes in the form of numbness or neuropathy from the oxaliplatin, or keep going until it stops working. And then try something else. And that something else is second-line chemotherapy. Well, that's not as good as first-line chemotherapy because we tried the best. So try second-line, and that still has some proven benefit, although it's less than first-line. And then do that for a period of time, either until that stops working or the cancer progresses. And then after that, there's not a great third-line option, unfortunately. Then often we'll talk about clinical trials. And so we looked at those guidelines and frankly, weren't happy with those and thought that there might be situations to do something more aggressive. And that's where these terms start to come in. So what I'll talk about today is, intraperitoneal therapy. That just means giving therapy within the abdomen. Regional therapy is the same thing. I'll talk about HIPEC, which is hyperthermic intraperitoneal chemotherapy. And so this may be an alternative for selected stage 4 patients in ongoing clinical trials and is under investigation. So that's a quote from the National Comprehensive Cancer Network guidelines. It can be an alternative in selected stage 4 patients in ongoing clinical trials and is under investigation. So so we can do this. It's present within guidelines. It's the right thing to do to try and push the envelope here and see if we can improve upon just a chemotherapy only approach. And this is also in the context of what we do know about localized gastric cancer, meaning it's not stage 4 and that surgery is the only known chance for cure. Chemotherapy and radiation are very important. Those are essentially the 3 ways to treat cancer: chemo, radiation, and surgery. But surgery is the only way to get cure. Okay. So is all stage 4 the same? So I'm going to show a few survival graphs here in the next few slides. So just to interpret a survival graph. So this is the axis that shows survival, and you want a curve that's higher up here. And so higher is better. And so what we did in this study is we looked at our patients that had metastatic gastric and had great responses to chemotherapy, and then we attempted surgery. And not all sites acted the same. So the sites such as distant organ, which is liver or lung, or those distant lymph nodes, those did the best. Or patients that only had washings that showed peritoneal disease. And I'll describe what washings are in just a few slides. But the patients up here did better and had a higher chance of survival. And here is the peritoneum down here. Similarly, this is a study we did over here on the left of patients who had gastroesophageal cancer, and we did chemotherapy and then often radiation, and that included sometimes sites of metastatic disease, and had approximately 20% 5-year overall survival. Now, one of the issues is when we're talking about how we have different treatment effects for different sites is that we can't do radiation to the peritoneum. And so we can do that to a lot of the other sites, such as liver and lung, even distant lymph nodes sometimes, but we can't do it to the peritoneum just because it's too diffuse of an area. Radiation is a local treatment that only works in an area. Okay, so now these are a few other studies that are just trying to figure out, should we be looking at doing surgery for stage 4 disease? And I won't get too much into these trials. I just wanted to show that there are good, high quality trials out there. But what they say, and they all kind of say the same thing, is that it appears that there may be a benefit to doing surgery, and we should study it further. We should not ignore surgery in the treatment of stage 4 disease. Now, most of these studies are studying the liver, the lung, bone, and distant lymph nodes. Now, the reason for that is because, again, surgery is easier on those sites. It's easier on the liver. It's easier on the lung. Sometimes distant lymph nodes, although not usually, but surgery on the peritoneum is much more difficult. We also have radiation. I know I just mentioned that in the previous slide, but we have that for these other sites. There may be a barrier called the peritoneal plasma barrier, which prevents chemotherapy from reaching the peritoneum. And there's some basic science studies that support that. In addition, when disease spreads to the peritoneum, it can create a whole host of problems that can prevent our patients from getting chemotherapy. It's a nasty disease site. It can cause obstructions of the bowel by kinking the small bowel, and it can also cause fluid buildup or ascites, and that can be very difficult to deal with. The tumors can produce fluid that builds up within the abdomen. Okay, now one thing I wanted to touch on is why is imaging so unreliable for peritoneal disease? And it just isn't very good at picking it up. So this is, again, a picture within the abdomen, and here we see the stomach, and it's thickened and white along its length. So this is the top part, so food comes down through that, and the tumor is really just spreading throughout the stomach. And then what we can see here is that it's jumped off to these little white dots on the lining of the abdomen. I took a close-up view here, and this is only about 1 millimeter thick. This is a magnified view. But if it's only 1 millimeter thick and our CAT scans are 2 to 3 millimeter slices when we go through the body with the imaging, that's why it doesn't show up. It's too thin for the CAT scans to show this up. Same thing with PET scans. It has to be relatively large, often 1/2 centimeter to 1 centimeter thick for those PET scans to pick it up. Now this is called carcinomatosis. That's when you can see visible white dots on the lining of the abdomen. Another stage 4 disease is positive cytology. So what we do here is, even in situations where we don't see white dots on the lining of the abdomen, we will put some saline within the abdomen and let it wash around, and then take the saline out and look at it under a microscope. If we find cancer cells in that, that is also stage 4. And of course, that makes sense why that doesn't show up on imaging, because it's microscopic. But we've done studies, and they're just both stage 4. They act similarly, whether you can see the white dots or we can find the microscopic cancer cells in that. And I always get asked, well, why can't you just go in there and cut those little white dots out? Well, we can, but we have to do something else, because these are just the white dots that you can see. And undoubtedly, there are other microscopic cells floating around. These are just the biggest areas of tumor where it's grown together that we can see it. Okay. Now, what about, I mentioned the difference between East and West, and I'll go over this slide. I don't want you to focus too much on these abbreviations here. I don't like abbreviations, in cancer when I'm giving talks, but the bottom line is all of these studies are really good randomized clinical trials, the gold standards that we use in medicine, where we compare one type of treatment to another type of treatment. What they were doing here is they were comparing surgery with something else. So either different types of chemotherapy with surgery, or chemotherapy and surgery versus radiation and surgery, just different things like that. But what I want to show is that here in our Western centers, in these high quality studies, look at the 3 and 5 year overall survival rates. That's what OS is. And it ranged between the 20s to a highest of 50%. Now, if we go to those Eastern centers from Japan, Korea, you can see that the numbers are much, much higher. Now we're in the 60s, the 70s, and even the 80s. And it's not that, Japanese chemotherapy is so much better, or it's not that the surgeons are so much better. Although, patients are much thinner in Asia, and surgery is easier, and they have a surveillance program. No, the difference is that the tumors are different, and they act very different. So I think this very clearly shows, roughly a 30% difference in survival. And I've been to Japan and have seen the differences in treatment, and it's just a very different disease over there. And there's some basic science studies that support that, looking at different immunologic profiles and other things. Now, the reason that's important is because there are differences in treatment for stage 4 disease between the East and the West. And so on the left here, this is an Eastern approach, and typically that involves putting a port within the abdomen. So that's what I'm showing here with this retractor, and that's a port underneath the abdominal skin. And then that leads to a catheter that goes into the abdomen, similar to the ports that you see, they go in the chest and lead into a vein. Well, this one is in the abdomen and just leads into the abdominal cavity. You can administer chemotherapy, not heated, but it can be repeated, often repeated weekly, and it goes into the abdomen to directly interact with the tumor. Now, what we've looked at more in the West is this on the right, which is HIPEC, and that's heated intraperitoneal chemotherapy. And so this is a perfusion pump here with a perfusionist to heat the chemo and run it in, and then it runs out. And here we agitate the abdomen, and the catheters go in and out of the abdomen. Okay, now, again, just to kind of reiterate, I think what I've done so far is, when we discuss why would we even perform surgery in stage 4 disease? Well, the options after first-line chemotherapy are limited. options after second-line chemotherapy are even more limited. We know that surgery is the only chance for cure in non-stage 4 gastric cancer. And as chemotherapy and immunotherapy improves, I think we need to consistently revisit this question, because it's not just surgery alone. It's usually surgery after some extended chemotherapy. And as the chemotherapy gets better, with each advancement, that may be the time to jump back in and see if surgery can help out again and improve survival rates. There are also many reports of a possible benefit to surgery. And a lot of these, techniques, they were just old studies. And what they did is they just did a new surgical technique or used heated chemotherapy. And then after they had performed that in 20, 30, 40 patients, they would just go back and look at the results. And they all kind of said the same thing, is that, we think there may be benefit, but it's in select patients and the risks were pretty high. And of course, there's never been the gold standard of comparing those surgical techniques to chemotherapy alone, which is really what we need to say that we need to step away from just doing systemic chemotherapy. So we still, we need more of those randomized controlled trials. Okay, so now I'm going to talk about HIPEC. So that's hyperthermic, which just means adding heat. Heat has a direct anti-tumor effect. The chemotherapy goes within the abdomen, works best on tumors that stay in the abdomen and aren't that invasive. And you can apply it directly to the tumor. And we also use chemotherapy that synergizes with the heat. And so it can be applied in combination with a cytoreductive surgery or a debulking, that's sometimes abbreviated CRS. But anyway, that's what HIPEC is. And that's the rationale behind it. Now, HIPEC is the standard of care for some tumor types, and those two are appendiceal tumors and mesothelioma. So I apologize, some of these pictures, may look a little gross to you, but I wanted to show you, how we use this and how it's a standard of care. And so this is an appendix here on the left. That's just about the size of a finger, and this is a tumor in the appendix, this little white area here. And this is an appendiceal mucinous tumor, and this patient got very lucky in that it showed up on imaging or caused some pain, and we cut it out, and that's the end of it. But if that ruptures, then it starts to leak a gelatinous substance, and that's what I'm showing over here. This is a very large bucket, where this is a patient where that had grown and ruptured and created all this fluid within the abdomen. So the surgery is to remove all that fluid, and then you can treat with heated chemotherapy for typically a couple hours, and that can provide a higher rate of cure in this disease. And so it is standard of care for these types of tumors. Mesothelioma is also a little different, but it's just a diffuse tumor that spreads along the inner lining of the abdomen. Now, as I'm showing here, it's often combined with a cytoreductive surgery, or what's abbreviated CRS, also called a debulking. There have been some recent studies about colorectal cancer, and so it's pretty controversial for colorectal cancer, because one of the older studies showed that there was a benefit in a randomized trial, but some of the more recent ones didn't show that. So that's an area of active controversy. But you have to be careful when you're talking about doing HIPEC in gastric cancer. It's not that soft tumor that we just scoop out and then treat with chemotherapy. No, it's in addition with a big surgery, and that can be a total gastrectomy, as I'm showing on the left. So the entire stomach has been removed, and we plug the esophagus into the small bowel, and that's a big enough surgery in and of itself. Often it involves a feeding tube, as I've shown down here on the bottom. And then when you add that heated chemotherapy, all the risks go up, and the risk of dying from gastric cancer surgery is low. Thankfully, it's 1% or less. It's a little higher nationally outside of centers of excellence, but when you add chemo, that probably goes up, the heated chemo. In addition, pretty consistently, there's about a 20% complication rate, significant complication rate from the surgery. Again, when you add the heated chemo, that goes up as well. And so, so we're getting better at this, and it's safer. But I think we just have to think before we do this, and make sure we don't hurt the patients with this technique. Now, this is the first randomized controlled trial for HIPEC in gastric cancer, and I'll go slow through it. It's a study out of China. Now, 40% of the world's gastric cancer is in China. There's a lot over there. and this is a very small study by their standards. It's only 30 patients in each arm. But what they did is they compared patients undergoing just cutting everything out, that cytoreductive surgery or debulking, versus doing that debulking and the HIPEC, the heated chemo. They used a couple drugs, mitomycin and cisplatin, and it was done in patients with carcinomatosis, those visible white dots I showed. And what they found is that there was some benefit to the HIPEC. So again, here's a survival graph here. You want that graph to be as high up on the chart as possible. That's a better survival. And so the blue shows the cytoreductive surgery in the HIPEC, and the yellow is the cytoreductive surgery alone. You know, it was pretty advanced disease, a pretty high tumor burden within the abdomen here, but it was a signal that this might work. And again, this is the only completed prospective randomized controlled trial. Now, around that time, there was also this study called the Cyto chip study, and this came out of France. And this was much bigger. So this is about 180 patients in one arm and about 100 in the other. And this was kind of trying to ask that exact same question that I just showed in the previous Chinese study. And but this one wasn't a prospective trial. It was a registry where they just go back and they collect things as they go along and go back and look at the results. But in the blue are the patients that had that cytoreductive surgery and the HIPEC, and in the red, just the cytoreductive surgery alone. And you can see a pretty significant difference. And what was really shocking here to a lot of us, and this increased our enthusiasm for studying this, is over here where we get out to 60 months. That's 5 years, so that's a 5-year survival rate of about 20%. And I know that's not great, but that's an improvement. And so so definitely worth studying and taking this into account, especially when I was talking about what the typical long-term survival rates are with metastatic disease, and the fact that we know that peritoneal disease acts worse than some of the other sites. Now, the other thing I wanted to show with this is this pie chart here, and I think this is important because it's not perfect either. And so these are the patients that recurred where the tumor came back, and in the blue are the patients where it did not come back in the peritoneum. It was just somewhere else, like the liver, the lung, or the bone, or something like that. But what that shows is that in the green and the red, most of the recurrences that came back were still the peritoneum. So the peritoneum is still a problem. We have a lot of work to do and get better at this. But there's some hope here. So with that in mind, we embarked on, this is the first completed clinical trial of any phase for HIPEC and gastric cancer in the United States. And so this was a single arm phase 2 study. And we were very worried about combining that heated chemo with the gastrectomy for all the reasons I just talked about, the high mortality rates. In some of those other studies, the mortality rate was between 5 and 10%. That's really high for a surgery. We like mortality rates of 1% or less. And so we didn't want to hurt patients by combining everything at once. So what we did is, okay, all patients got systemic chemotherapy, that's standard of care. And then after they completed systemic chemotherapy, we offered the heated chemotherapy only. So not a big surgery with it. We did it through a minimally invasive technique, meaning laparoscopy and using small incisions. And so you can see where the chemo goes in here and out here. This is a pretty easy surgery to tolerate. You're in the hospital for 2 to 3 days, and it includes a diagnostic laparoscopy. So I talked about how difficult it is to look at the peritoneum with CAT scans, but we go in with a camera each time to see how things have responded. But really, regardless of what we saw, we would treat with the heated chemo. We could repeat that, and if we got to the point where the cancer outside of the stomach on that peritoneum disappeared, meaning the biopsies were negative, we did washings, and we couldn't find any cancer cells, then we offered a gastrectomy alone. So not the gastrectomy and the heated chemo, just a gastrectomy, because we felt like we had gotten rid of the stuff outside of the stomach. Now, we did that in 19 patients, and it was a small study, and these are the results. And so patients did live longer than you would expect from some of the numbers I talked about. Now, I'm cheating a little bit because this is a single arm. I don't have that randomization that you really need, but there was a signal here that it worked well. But that's not really why we were doing it. We were going for cure. And I had 1 out of 19. 1 out of 19 patients is over 5 years out and getting to about 7 years out, and the cancer hasn't come back. And so we think that's a cure there. That kind of gets to the question I'm going to answer at the end. But it was a patient that just had an awesome response to chemotherapy, and we pushed the envelope doing this. But we weren't happy with 1 out of 19. 1 out of 19 is not good enough. And so then we embarked on our next trial, and this is more aggressive. Now, it's very similar in the way we start off with. So again, it was patients with that peritoneal disease, and everybody had to complete standard of care systemic chemotherapy. and then having undergone at least one of those minimally invasive hypecs. We get a view of the peritoneum, we do the heated chemo, and at that time, if it looks like we could cut everything out and get a patient through a surgery safely, then about a month later, we did that surgery I've kind of been bad-mouthing a little bit, where we add everything together, where we did the Cyto reduction, the gastrectomy, and the heated chemo. So that's the difference between this and that other trial, is we got more aggressive at the end by combining everything together with a aggressive surgery. And this is the survival curves here. We did this in 20 patients, and the survival rates, again, they look better than what you might expect. The survival rate's a little bit higher, and now we have 3 patients where the cancer hasn't come back, and we're getting close to 5 years, over 5 years in some of them. So that's still 3 out of 20. I mean, that's not great, but it shows that, you know, some of those other studies, like that French study, which showed a 20% long-term survival, it's probably real, and so definitely worth still trying this and studying this. So how do we take these trials into standard of care, or how do we approach patients? Well, this is one way we've tried to explain it. So this is on the left, this algorithm here is how we approach patients. So of course, all patients with this disease that is spread to the peritoneum get first-line chemotherapy. And then they go to multidisciplinary conference. And our typical length of first-line chemotherapy is at least 8 treatments. It's a balance between, you know, we want to strike while the iron's hot, and we beat down the disease as much as possible, because chemotherapy is so important. So we don't want to get to it before it starts to regrow, and also before we see the side effects of chemotherapy, such as neuropathy. But it can be 8, 10, sometimes 12 treatments. But then we take it to a multidisciplinary conference. So this should be done as a team. You know, we want the medical oncologist, the chemo doctors there. We want radiation oncologists. We want pathology, radiologists to interpret the imaging. Just put it all together and really think about this. And we do that, and then we have 2 options at that point. One is either laparoscopic hypec, so that first, you know, smaller surgery, or second-line chemotherapy. And of course, the patients have the ultimate say here and are helping us decide this. And then after the laparoscopic hypec, we can go back to multidisciplinary conference, and then we have another decision to make. Do we do the whole enchilada here, the gastrectomy, the cytoreductive surgery, and the hypec? Or do we repeat the laparoscopic hypec? That can be a tough decision. Or do we do next-line chemotherapy? Trials are always a good option. So that's essentially how we go through this. But I think just working as a team is the important concept there. Also, there was this 2018 Chicago consensus. A bunch of experts got together and just talked about hypec and peritoneal surface malignancies and how we treat this with different ways. So that's something you can find online. It's just a nice summary, and it involves or describes things like cytoreductive surgery and hypec, this thing called NIPS, which is a neoadjuvant intraperitoneal and systemic therapy option. And that just means giving both chemotherapy within the abdomen, but also IV at the same time. And so that's, we're also seeing some of that come out of Asia. Laparoscopic hypec, I've talked about a lot about that. That's kind of our approach, to take a stepwise approach before we jump into a big surgery, and of course, trial options. Now, I just wanted to show a few other studies we've done to just try and figure out a little bit more, what's the right place for aggressive surgery like this. And so I've mentioned several times that I don't have that randomized controlled trial. I'm trying to get that up and moving in the cooperative groups and the big national groups, but it's been tough to get that through those organizations. And so what I did is I went back and I did my retrospective study. So again, I'm cheating. I just go back and kind of compare patients that have had standard of care systemic chemotherapy. And I try to be very honest here, and these were patients that, for example, insurance may not cover this. That happens about 15% of the time, or they just didn't want to go through this path towards surgery, or something else where they just got systemic chemotherapy only. And I compared it to patients that underwent this laparoscopic hypec approach. I'm sorry, it's in yellow, it doesn't show up great. But now there's a difference here. Again, it looks like the laparoscopic hypec's a little higher, but when we look at this with statistics, we could not prove with statistics that it was a significant difference. So then I go over here to this other graph, and now we've split things out a little bit different. And now it's that blue standard of care systemic chemotherapy only, compared to the patients that had hypec but no gastrectomy. That's what no resection means, versus the patients in the green that had hypec and gastrectomy. And if we can get to the point where we see the gastrectomy and hypec, well, then the survival is much greater, and we do get that statistical significance. But again, it's kind of cheating to do that, to go back and look at them retrospectively, because all sorts of things can mess you up. It's best to start from the beginning and allocate patients to different treatment arms to really know what's going on. The other thing we did is we were looking at variables that could just predict how patients might do better with this HIPEC approach. So a couple things that we kind of picked up on and we wanted to study when we saw patients in clinic. One was the presence or absence of ascites. So again, ascites is the fluid that builds up within the abdomen from the tumor. And patients that had no ascites, as shown in the blue, again, that survival curve's higher, that's better, compared to the patients that had ascites, as shown in the yellow. So I think when we saw this, that there's such a difference, we have to be more aggressive with the ascites or have better systemic therapy or just do something different or consider a different systemic therapy trial, something, because going through this HIPEC approach wasn't as beneficial in those patients. The other thing we looked at is what's called the PCI. So you'll read about that when you read about HIPEC. That stands for Peritoneal Carcinomatosis Index. And it's just a way that as surgeons we have for classifying the disease. We break the abdomen up into quadrants and give it little scores and add it up. Lower number is the best, higher number is more tumor. And this is kind of what you would expect. So the patients in blue just had the positive washings, meaning no visible white dots, and those patients did great. And then the patients in the yellow had a low PCI, so just a little bit of tumor within the abdomen, less than 7. And then patients in the green had this PCI that was greater than 7. So we can kind of use this to help give information to patients and say, this is what we expect after this, or this is where it's right to be aggressive with the surgery. So it just helps a little bit. Now, reasons to give chemotherapy before surgery. I think sometimes when people think about surgery, they think, well, it's always the gut reaction to jump into surgery. That's the only potential chance for cure in localized patients. But chemotherapy is really important before this. And so in localized tumors, we know this because we know that chemotherapy shrinks the tumor. It helps us get negative margins, meaning we get all the way around the tumor. We can assess the therapy response in the tumor. And we avoid unnecessary surgery. We know where surgery really hits that quality of life. And we can assess tumor biology. So it probably only makes sense to give chemotherapy within the abdomen if we're seeing a response, when we give it via vein as well. You can prevent spread. There's kind of this theory that if you manipulate the tumor during surgery, it can sometimes spread. We're very careful with that during surgery, but chemotherapy may help with that. And patients tolerate chemotherapy better before a big surgery. And that just makes sense. Once you've had a big surgery, it's very difficult to tolerate further therapy. So using all those reasons, we think that's the reason why we start with systemic chemotherapy. And I've looked at it many times, and that response to that first chemotherapy is the best predictor of whether HIPEC and gastrectomy works or not. So we got to see the tumor beaten down with the chemotherapy before we jump in with a big surgery. And again, just to show you how big this surgery is, these are the 2 types of surgeries that we perform with HIPEC. So this is a normal stomach here, and you can see you go from having a big bag to a little pouch here, or just a little pipe in a total gastrectomy. And oftentimes these can require feeding tubes. I talked a little bit about the risks of death and complications, and but there's just a big hit in quality of life. It can change. It does change the way you eat for the rest of your life, even with a subtotal. And so we just we want to make sure there's a benefit here, because we know we do impact quality of life when we perform these surgeries for sure. Okay, so in the options to give treatment before gastrectomy, so we think it's important. We know that systemic chemotherapy is important, but there are other things we can do. So my approach is the laparoscopic HIPEC approach. There's also intraperitoneal paclitaxel, and I'll show some more slides on that in a second. There's PIPAC. I know these abbreviations, they get crazy, but that's pressurized intraperitoneal aerosol chemotherapy. So it's just a way of applying some pressure within the abdomen in addition to the chemotherapy. There's some theory that it may cause penetration to be a little bit deeper. It may distribute the chemotherapy a little better. It's really hot in Europe right now, and so it's starting to be studied here in the U.S., but not clear if there's really any benefit to that beyond just doing heated chemotherapy. It's kind of a crazy approach too, because when you aerosolize chemotherapy, there's a risk of it. The people working on you can inhale it, and so and some of their approaches is once they start the aerosolized chemotherapy, the whole surgical team and even the anesthesiologist has to leave the room, and so you have this long IV going out of the room, and the anesthesiologist is looking outside, pushing the drugs, through the window, watching the patient and the vital signs. There's also this neoadjuvant intraperitoneal and systemic chemotherapy approach. That's also called bidirectional or NIPS. So anyway, the bottom line is we're all trying to find something in addition to systemic chemotherapy to beat this tumor down, so that when we do that gastrectomy, we have the highest chance of providing a benefit for patients. Now I'm going to talk a little bit about the Asian approach. So I was lucky enough to be the American College of Surgeons traveling fellow to Japan, and I got to meet a lot of the major leaders in gastric cancer surgery in Japan. It's very common over there. They have a national screening program, roughly a 10% risk of getting gastric cancer for the Japanese. But it's very different. It's a very different tumor. I could see that when I was over there. But this is their approach. So I had the chance to meet Professor Ishigami down here, who was the principal investigator for this Phoenix gastric cancer trial. They have one going on in China now called the Dragon, so they kind of have their different names for it. But and so it's patients with peritoneal disease, and they get randomized to intraperitoneal, that's what IP stands for, paclitaxel plus chemotherapy. S1 is a type of chemotherapy that only works in Japan. It's a very different population, and they metabolize it differently. So it's an oral 5-FU pill, but it doesn't work here in North America in our population, just due to biologic differences. But anyway, they did intraperitoneal paclitaxel plus some chemotherapy versus chemotherapy alone. Now, this was a negative trial. I should state that first off. It did not show a significant difference, but when you look at subsets, and they had some problems with the trial where some patients jumped from one arm to the other, it looks like there might be a benefit. So again, this is still worth studying. And so this is how they approach it in Japan, is that they try and control the intraperitoneal metastases with intraperitoneal chemotherapy, and that paclitaxel is just a big molecule that tends to stay in the abdomen. And if those cancer cells disappear, kind of similar to our HIPEC approach, if they can get rid of the white dots and the positive cytology, then they'll perform a laparoscopy, confirm that, and offer a gastrectomy. So it's a very similar approach, just a little different way to try and get to the same outcome. Now we're studying that as well. So this is our single arm phase 1 trial, and again, everybody gets systemic chemotherapy, and then we perform a laparoscopy and we do a port. So these are one of my patients where the port is going into the abdomen and the catheter goes into the abdomen, as I've shown here. And we do intraperitoneal paclitaxel. Now, a lot of times in Asia, they'll give chemotherapy via vein within the abdomen, but we wanted to prove that this chemotherapy within the abdomen works, because we know it works via the vein. So we wanted to get as high a dose as we can within the abdomen to see if it works. And so it's once a week treatment for 3 weeks, then a week off, then once a week treatment for 3 weeks. And then we go back in with a camera and we see if it works. And then at the end of that, we have the options of, potentially gastrectomy and HIPEC. We can continue this intraperitoneal paclitaxel treatment if it's working, or in situations where it doesn't work, we can go on to the next line chemotherapy. So we're at the highest dose level now, and the trial's going well. There are some side effects, some issues with ports. We've had some leakage and fatigue, some lowering of the white blood cell count. But again, just what we're seeing in Asia, we thought this was definitely worth studying. So back to the original question, I'm wrapping up here. Can stage 4 gastric cancer be cured? Well, early phase trials demonstrate you can obtain 5-year survival. So if you want to call a 5-year survival a cure, then the answer is clearly yes. But there are rare recurrences beyond 5 years, and we're just very early in this. So I try not to use the cure word too much, and really say yes. In my early phase trials, I can prove that we can get to 5 years with chemotherapy and aggressive surgical approach. But listen, I'm not happy with the percentage of 5-year survivors we're getting. 20% still isn't high enough. So often we're planning for recurrence while we're hoping for a cure. Again, we keep going at it. We're always looking for new treatments in the pipeline. Everything I hear that's out there, like this intraperitoneal paclitaxel approach or other things, I'm going to work it in. It's my passion to try and get to a cure here. But this is often how I approach it with patients now. So first of all, I start with discussing median survival rates. I outline the standard National Comprehensive Cancer Network guidelines, which are chemotherapy only, and that if we're doing this other stuff, it is considered, experimental, or definitely pushing the envelope. Now, we can talk about that, all these older studies that showed selected patients underwent surgery and did well, but I have to be very upfront, we don't have that gold standard randomized controlled trial that I really need to show a benefit yet. But we have early phase trials that suggest a benefit, and we're trying to get to the randomized trials. So the benefit really is still unclear. So we have to outline the risks of surgery, because that's we have a risk-benefit discussion in surgery, and I know I can talk about the potential for benefits, but it's just so early. But I can really talk about the risks, because those are pretty clear. And I just think a stepwise approach makes sense before we do a big gastrectomy and impact quality of life. You know, trying to do something, just not jumping into that gastrectomy HIFEC all at once, but using systemic chemotherapy, going to multidisciplinary conference, doing a laparoscopic HIFEC or the intraperitoneal paclitaxel, then going back to multidisciplinary conference and talking with the patient, having results of the diagnostic laparoscopies at each stage of treatment, and then deciding whether we go for aggressive surgery. I do think, though, that you know, it's not something where you just want to stay on chemotherapy for too long until it stops working. It has to be a plan where you work with your medical oncologist. So after, you know, about that 8th treatment, we have a plan. Are we going to jump in now and go, or maybe it's 10 treatments, maybe it's 12, but much beyond 12, I think oftentimes we'll miss the boat here. So in the end, I got to say, you know, patients come first here. You know I talk about data and those survival curves, but you know, every part on that survival curve is a patient's life. And so it's just been a real honor. You know, I did all the surgeries in the trials that I've presented and have taken care of those patients. And so it's just been a real honor to assist patients with participating in these trials, and just, you know, I'm inspired by the bravery that they show in doing that. I got to thank some funders. Although I've never accepted money from a pharmaceutical company, I have accepted money from a patient, Holly Clegg Gastric Cancer Research Fund. It's a patient that was on one of our trials, and unfortunately, you know, was not one that got a cure. But her family has been so gracious in supporting our research and allowing us to keep these trials going. There's the No Stomach for Cancer Award for gastric cancer research, also just a great, you know, organization that has helped fund us and keep this research going. And then even MD Anderson has helped us with institutional research grants to keep this going. And we haven't accepted, you know, any or gotten any NIH money or any other funds for this. It also takes a team. I got to thank everybody that's part of this team. So this is who you see in my clinic, and this is Catherine, our nutritionist. We're just so lucky to have a nutritionist at every clinic visit for our patients, because it's important here. Shoing, who runs these trials and just runs them to near perfection. And so, you know, none of these trials would have been completed or followed up or ongoing without Shoing. And then there's Heather, our nurse practitioner, that just keeps things running and organized and helping us treat patients. So anyway, I know I'm the one here talking, but it's not just me by any means. It really does take a team, and that's not even the whole administrative team that helps us with research and is kind of behind the scenes. So I did want to briefly mention the International Gastric Cancer Congress, which we'll be hosting very soon, March 6th to 9th here in Houston. I won't. It was supposed to be in 2021. I won't complain too much about all the pandemic-related problems we have. I'm hoping the weather is this nice. It's mainly going to be a lot of virtual people attending since it's an international meeting. But listen, on Wednesday, there's going to be a patient session. And so I'm really excited about this. It's going to start off with just an organizational overview of all these different organizations that are dedicated to patients, patient advocacy, education, helping patients, funding, research, just a lot of great organizations here. Of course, Debbie's Dream is involved, critical here, and they've been really helpful in helping us plan this session, so I thank them for that. Then there's a kind of a patient education session. There'll be a lot of fun with, you know, a food advocate and chef, and then talking about how drugs get absorbed after gastrectomy and you know, pregnancies and mental health, and just a lot of good stuff here in nutrition and psychosocial well-being. So now this is going to be free. So you can get a complimentary registration. So I just want to leave this on the screen for a little bit so you can jot this down, or hopefully this will be available on the Debbie's Dream website after this. But you can visit the gastriccancerconference.com website. And if you use that code IJCC22patient, it'll provide free registration. So it's virtual. So it'll all be live streamed, and you can catch the that patient care symposium on March 9th. The rest of it is a lot of doctor talk, but if you wanted to register for that, there's a cost associated with it. But this part, certainly we want to get out to patients. So please put the word out by all means. Okay, and then I think I turn it back over to Brittany.
Thank you so much for sharing with us today. We did receive some questions during your presentation. I know we're a little brief on time, but I'll go ahead and ask some of the questions that we have here. And if your question doesn't get answered, please feel free to reach out to us by emailing programs@debbiestream.org, and we'll try to get back to you with any questions from our expert. So the first question we have, Sandy says that her father has stomach cancer with liver metastases, and it was found under the fundic gland polyp. She says he's currently taking omeprazole for protecting the stomach. How can they replace omeprazole if it caused a polyp? That's her question.
Okay, so let me make sure I understand. So we are in the setting of liver metastases.
Mm-hmm.
Okay. And then something to protect the stomach because they feel like the PPI caused a fundic gland polyp. I wouldn't be so worried about a fundic, gland polyp being due to a PPI. So proton pump inhibitors, there's no relation between those and gastric adenocarcinoma. Now you can't, if you didn't want to do a PPI, the proton pump inhibitor, then you could try different things. They're topical antacids, this drug called Carafate, different things to protect the stomach topically, even an H2 blocker like Zantac or Pepcid. Now those proton pump inhibitors can, or theoretically might be related to neuroendocrine tumors, but those are a much different type of tumor. Those are slow growing and just not that bad, especially in the presence of liver metastases. So I'm a little reluctant to provide too much kind of treatment recommendations without knowing everything, but in the presence of liver mets, I wouldn't feel bad at all keeping that PPI going to protect the stomach while undergoing treatment.
Thank you. Next question. Sandy wants to know, she says, hold on a second. Actually, Teresa, she says HIPEC is being used only in clinical trials with certain patients. What markers or indicators does the patient need to have to be part of a HIPEC trial? She also wants to know what the trials are.
Yeah. So first of all, I've already done 2 phase 2s and a phase 1 trial in HIPEC. So I'm doing it off trial. I think it's okay to do that. That is a little bit controversial, and you have to have those talks with the patients. But I'm kind of in limbo now, in a sense, where I've done the early phase trials. I'm not sure it would help to do another one. I'm waiting to start the randomized controlled trials, across the country, trying to get those up and going. And so the first thing I would say is you can offer it off trial. The second thing I'll say is that I know there is an ongoing clinical trial of HIPEC at the NIH that I think is still going. As far as markers, honestly, it's I think that response to systemic chemotherapy is so important. It's not so much looking for a marker like HER2 or PD-L1. It's that response to first-line systemic chemotherapy, and then having a laparoscopy to stage the peritoneum to determine if HIPEC is the right way to go.
We have someone, Jessica asks, is it possible for lung mets to be completely removed with chemo?
I think it's really tough to say that anything can be completely removed with chemotherapy. That's why I think surgery is still an important part, or radiation, some kind of local treatment. So for instance, it can cause a complete imaging response where the lung lesions can go away. And in that situation, that's great. And sometimes we see that happen for a long time. And we love it when we see that. I think a lot of times, though, we will see it come back, and then we have to do something else like radiation, occasionally a surgery. We usually try radiation first because it's better tolerated and less risk. But so I know that's kind of a long-winded answer, but it's pretty rare where they'll go away and never come back, and we usually have to get involved in those select instances where we'll do some radiation or possibly even a surgery to that as well.
Okay, Sandy asked, do you know of a medicine for a GNAS mutation?
No, that, that's a little bit outside of my field. I think, when people are looking at those different markers, essentially I work with my medical oncologist on that, and we're always looking for nutrients. We have a phase 1 group here that has a lot of novel agents, and I'm sorry, I don't know if they have anything for that mutation.
Okay, and Corey Peck wants to know, do you have recent data on standalone HIPEC efficacy? I'm not sure, you might have covered that.
Yeah, I think it's a good Yeah, it's mainly, you know, these early phase trials. So I have 2 phase 2 trials and 1 phase 1 of using HIPEC for gastric cancer in some regard. I kind of talked about the different approaches, but I have not, you know, done data, if you say standalone, on just going in and doing gastrectomy and HIPEC, you know, right off the bat. That's not my approach. I try and take a staged approach, but there is some data out there where they've done that, and it's you know, it looks like, you know, again, they kind of saying select patients that have had a great response to chemotherapy. It may be beneficial, but the risks are pretty high with that. So I think taking a staged approach is a little safer, and I think our results are a little bit better.
Perfect. Unfortunately, we are out of time for more questions today, but Dr. Badgwell, we'd like to thank you again for joining us and sharing your expertise. If you can click to the next slide, please. We would also like to thank our webinar sponsors, our platinum sponsors, Amgen, Daiichi Sankyo, and Merck, our silver sponsor, Bristol Myers Squibb, our bronze sponsor, Seagen, and we'd like to thank all of you for tuning in today. To view any of our recorded webinars, please visit our lecture library on the website at www.debbiestream.org. And this concludes today's presentation. Thank you so much for tuning in.